Hey, well, welcome to this pharmacology drug class review on the vitamin K antagonist warfarin. In this session, I'm going to explain why warfarin actually still matters and has a place in therapy. Yes, it's a complicated drug with a complicated history, but I'm going to make it easy to understand, clinically relevant, and if applicable, even help you prepare for your exams. Hey guys, I'm Dr. Busti, and thank you for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind pharmacology and the drugs that we use. Because when you understand the why, the how becomes easier because mechanisms of action start to predict therapeutic effects, side effects, contraindications, drug interactions even at some level, monitoring parameters, and counseling points. Okay guys, as with all of the drug class reviews that I do, I will cover core content that leads us to the clinical application. So we cover first things like what drugs make up the class, right? And some context of how the class looks compared to other drug classes. Indications, uses, what is the net benefit or use or reason to use this class? Pharmacology, okay, this is where that stuff really comes alive, that extrapolates over to understanding why we see side effects and monitoring parameters and do things the way we do. And then we're going to merge into that clinical knowledge application, and then we'll kind of pull it all together. One of the things that I want to do is start off with the covering of the individual agents themselves. Now, it's one, right? There's only one vitamin K antagonist, and it's warfarin. One of the things that I put together for you is a table, and again, this table is available at thisiswhy.health for you for free. Those of you joining us on our podcast channels, I will do my best to kind of walk you through it, but in summary, each column represents a class of or subclass of anticoagulants. The first one being warfarin. And the reason it's the first one that's listed is because a lot of times based on the history, it's the thing that we compare it back to, especially for our oral anticoagulants, are known as DOACs. Okay? And so what I try to do is just summarize them. I think it's important to have a framework or perspective when you learn drugs and classes of medicines. How do I pick this drug class, or why do I pick this drug class over this one? How do I use this drug, or some nuances? Maybe it's sometimes we pick drugs because of side effects or drug interactions or cost. It does matter, but what matters is that you have a good reason for it, and it's patient-oriented and specific to the best interests of your patient. So in this column, you see here that over here we have warfarin, okay? Brand names Coumadin, also historically also known as Jantivin. And then each row represents a characteristic. Things like the size of molecular weight, the routes of administration that it's given, the basic mechanism of action. Does food interact with it? What drug interaction potential is there? And with warfarin, that's huge, right? We have cytochrome P450, 2C9, 3A4, all right? Those are big problems. And then this drug is also subject to genetic polymorphisms, especially to VKOR and also 2C9 that we'll talk about briefly. So I try to summarize those for you and compare them to the other drug classes so that you have the big picture. Now, is it encompassing of everything? No. Is this table complete and comprehensive? No. No, it's just meant to give you a reminder and a snapshot of how this drug fits compared to the other agents. Now, next we're going to cover the indications and most common uses that then lead us to, yes, the benefit and then that pharmacology. Now, indications most commonly or twofold. The prevention of cardioembolic stroke or secondary prevention in patients with AFib, right? And then VTE, deep vein thrombosis and pulmonary embolism. Now, those two things have been taken over by the DOACs, especially showing equivalency and sometimes superiority to warfarin, and those would be our factor X inhibitors and our oral direct thrombin inhibitor, dabigatran. But we also can use this drug, warfarin, in even secondary prevention of myocardial infarction if no other option exists or some reason for contraindications to the other ones. But the thing that I really want to point out here, and this really kind of leads to the net benefit of this class still, which is unique indications where this drug is still preferred, and that's antiphospholipid syndrome in patients with mechanical heart valves, okay? That's just their value, and where the other drug classes, while they may be evolving and emerging with new data, still historically are not considered the drugs of choice, okay? So the next thing I want to dive into is that net benefit of this drug class in comparison to, you know, why the other, compared to other drug classes in the anticoagulants. Now, one is just the fact that it's been around. We have an extensive history on warfarin. And so the good thing about that is we understand its issues. They're not great issues. They cause a lot of headaches and they're time consuming, but we have a lot of experience with them. Now, some of the newer generation of clinicians coming through the pipeline may not see as much and may not, but I grew up on warfarin, unfortunately. I worked in actually a Coumadin clinic. That's all they did, right? That was what back in my day being a pharmacist. And I learned a lot from that. I learned a lot about the drug and I saw the complexity of management, but it worked. If patients were compliant, followed the recommendations, it actually worked. And it's a cost-effective option if you have somebody who's going to be compliant to their diet, not changing of medications, be compliant with their medicines, and follow-up, right? So there are issues with it, but it does work and it has its unique indications that still make it useful, okay? So let's not just throw it all out. Okay, next is, let's dive into the pharmacology, because remember, this is, when you understand why this drug works the way it works and how it works, then it makes sense why we have a delayed onset of action and requires multiple days of potential bridge therapy. It makes sense of why we have certain monitoring parameters the way we do, drug interaction issues, and then where genetic polymorphisms play a role, okay? So one of the things that I put together for you here is a figure or diagram of showing you the metabolism of things going on in the body, specifically vitamin K dependent clotting factors. So remember, warfarin is a vitamin K antagonist, VKA, vitamin K antagonist. What does that mean, right? Well, it's primarily impacting the recycling of vitamin K, which is necessary in order for the functional activation of the clotting factors 2, 7, 9, 10, protein C, and S, okay? 2, 7, 9, 10, protein C, and S, okay? Now, up here in this diagram, you see that we have vitamin K dependent clotting factor. It's made by the liver, but that just because it's made doesn't mean it's activated. So it's a non-functional clotting factor. It gets activated in the presence of reduced vitamin K. It must be there. And gamma glutamyl carboxylase is the enzyme that uses that reduced vitamin K to carboxylate the clotting factor. And by carboxylating it, it actually makes it active and able to interact with other things around it, okay? So you can make clotting factors and prevent them from being activated. So then when you have that vitamin K, it's now in an oxidized form, so it has to be recycled back to the reduced form, and that is through VKOR C1, which is vitamin K2,3 epoxide reductase. So it's taking the oxidized vitamin K and it's reducing it back. So it's just a vitamin K recycle. Okay? But this is the target of warfarin. And you see two different arrows listed here. One is thicker and more bold than the other. because warfarin is a racemic, basically, molecule mixture. It has an R enantiomer and an S enantiomer. The S warfarin is the super warfarin, right? It's the most potent exertion on this effect for its anticoagulation. So anything that affects the S isomer or enantiomer of warfarin is going to have the greatest impact on overall variability in the anticoagulation provided. The R isomer still has some influence, but it's not to the same degree. And you can also see that they're metabolized differently. S warfarin gets metabolized via cytochrome P452C9 over here, which is a phase 1 metabolic pathway. And the R enantiomer is primarily metabolized through phase 1 pathway 3A4. Okay? So drugs that interact or inhibit those phase 1 metabolic enzymes significantly can influence the levels of those two isomers. So drugs, for example, like trimethoprim sulfamethoxazole, which is one of the more potent, strong inhibitors of 2C9 known, right? Other ones like metronidazole, fluconazole, those drugs, amiodarone. Amiodarone inhibits both. So when you start somebody that's on stable doses of warfarin on Bactrim or amiodarone, you've got to reduce the dose of that warfarin. That's how severe and significant the drug interaction is, okay? And so any drugs that do that, so metronidazole, fluconazole, amiodarone, drugs like Bactrim, those are very relevant, okay? So down here we have the warfarin's mechanism of action and metabolism. We have the vitamin K recycling, and then we have the functional activation of newly formed clotting factors. Now I want to stop right here and make a comment, because this is really important to understanding why the anticoagulation effect of warfarin is not immediate. So follow, okay? Once a clotting factor gets functionally activated, i.e. carboxylated, for the life of that clotting factor, it's available for activity. So when you start somebody on warfarin, your body has floating around activated clotting factors, 2, 7, 9, and 10, protein C and S. Each of those clotting factors have different half-lives and durations of action, okay? So that means you have to wait for, as you inhibit the new ones that are being functionally activated, you have to wait for the old ones that have been activated to go away. And that's why there's a need for bridge therapy, because you have to, in an acute thrombotic episode of something going on in the patient, you have active clotting factors present. This drug, warfarin, is only preventing the newly formed clotting factors being made from being activated. Do you follow me? So the existing pool that are floating around in your body at the time that you start warfarin have to fade away, and they have different half-lives. And those half-lives give variability, and why it takes up to 3 to 5, sometimes longer days to get somebody to a therapeutic INR, or therapeutic level of anticoagulation. It's very frustrating, but that's why. Now, protein C and S, interestingly, are kind of these endogenous or natural, kind of like, they kind of regulate the coagulation cascade and prevent it from going on. So they're kind of almost like a anticoagulant effect, if you will, very small. Everything in our body is a balance, isn't it? We don't want to bleed to death. We don't want to clot to death, right? We gotta have this balance. But when you look at the protein CNS, they have the shortest half-life. That means that when you start something on warfarin, they're impacted first and foremost. So what that means is, if I take away the regulation of the coagulation cascade quicker, then I allow the coagulation cascade to actually flow and make more fibrin, which leads to a clot. So in a early on, when you initiate somebody on warfarin, especially in high dose, which is not recommended, you can favor the environment towards having only floating activated clotting factors with less regulatory protein CNS to keep it under bay. And so what ends up happening is the patient, unfortunately, starts to form these clots. And that's the hypercoagulable state that Coumadin can create in the acute phase if they're not receiving some other parenteral anticoagulant like unfractionated heparin or a low molecular weight heparin. Okay? And so that's why it's important that someone with an active clot requires bridge therapy for that very reason. Okay? So that's a lot. But that's why there's those variations in why warfarin needs a bridge therapy with a parenteral coagulant. Now, when we look at the coagulation cascade, and you have to put it in the context of platelets also, because what at the end of the day is forming is a clot. This is all balance, right? Because again, you don't want one or the other extremes. Now, in certain situations, we are trying to control that. This is why we're using an anticoagulant. But the intrinsic pathway is primarily influenced by our heparin molecules. Unfractionated heparin, low molecular weight heparin, fondaparin X mainly. The extrinsic pathway over here, which is typically manifested most in the lab monitoring pathway of the PTINR, is primarily affected by warfarin. Okay, so you see that here. So remember, warfarin affects 2, 7, 9, 10 protein CNS that all kind of regulate more. And so that's that PTINR is more manifests more the effect on the labs. But remember, each of these clotting factors has a half-life. And unfortunately, thrombin has one of the longer half-lives. It can be days, right? So you have some clotting factors being affected before others, but other clotting factors still being around. And so that's where that bridge therapy becomes huge. Okay. Now, this is working on the coagulation cascade, which means or implies, if you go back to the indications that I said were primary indications, they were for venous thromboembolic events, DVT, PE, prevention of cardioembolic stroke and AFib, where you're pooling of blood in the atrium. Okay. But I also mentioned things like secondary prevention in myocardial infarction, which is an older indication. Most people don't do that as much. There's a few patients still out there that do it or on it. Why is that? Well, because at the end of the day, there are platelets present, and there's fibrin present in clots that are arterial versus venous. They all have red blood cells, they all have fibrin, they all have platelets. They just vary in their composition and the percent of their composition of that thrombus. So venous thromboembolic events favor more the coagulation side, which is why warfarin is used, which is why heparin is used, fondaparin X and low molecular weight heparins and direct thrombin inhibitors all favor clots that are venous thromboembolic events predominantly. But that does not mean that aspirin doesn't protect you. It does, just not to the same degree, right? So anticoagulants work better on venous thromboembolic events for that reason, okay? All right. Whew. It's a lot. It's cool mechanisms, cool pharmacology. When it makes sense, it comes alive. So let's now transition to taking that core knowledge where I've started to bait and lay this groundwork and the foundation for the clinical application and some of the things that we see. And let's now dive into that clinical knowledge and application piece. Okay, and the first thing that I want to talk about is what to do before you start, before initiation. Okay, when you look at that, you need some labs because patients, obviously, you're making them increased risk of bleeding. So we need to look for trends that would suggest they're bleeding or leaking blood from somewhere. We need to look for things that are going to predict that these drugs may not work as well or work too well. So the CBC, complete blood count, right, is looking at that hemoglobin, hematocrit, of course white blood cells, platelets. If you get with the differential, you get all the other indices with it. But that hemoglobin and hematocrit is important for a baseline. These patients are at risk for bleeding. They can slowly leak blood and become anemic, where they get lightheaded, weak, short of breath, feel dizzy, all these things. Okay. Why the serum creatinine? Well, I mean, warfarin isn't really necessarily dosed by the serum creatinine. However, in renal impairment or renal failure, those patients can develop what is called uremic platelet dysfunction, which increases their risk for bleeding, right? So those conditions put that at risk. If you use bridge therapy with a heparin, then many heparins, including fondaparinux, are renally dose adjusted, even some of our DOACs, right? So if there's any crossover, bridge therapies, conversions going on, then you need it for that reason. What about the liver function test and liver enzymes? Well, liver function test is talking about the functionality, the work capacity of the liver to do its job, which is to make albumin and other proteins, but also to, conjugate bilirubin so we can get rid of it. But it's also to make clotting factors that have to get functionally activated, right? That influence our PT, INR. That's why. Liver enzymes are talking about liver damage, so something's wrong, hepatitis, cirrhosis, whatever, fatty liver disease eventually, right? All those things that can lead to liver damage and impact the ability of the liver to not only metabolize warfarin, get rid of it, okay, in some degree of balance, but also those clotting factors. And then lastly is consideration of the genotyping of patients, if you have the ability to do that. There is growing efforts and tools that are available to assess patients for genetic polymorphisms, but there are two in particular that can influence predominantly the dosing of warfarin, if you know it up front. If you don't know it up front, then you just start off with standard doses and you titrate until you get the desired anticoagulation effect, which can take up to 5 to 7 days to do that. Okay, and in that time, if they have an active clot, they're on bridge therapy, which many times mean they're in the hospital or they're administering subcutaneous injections of things like enoxaparin as an outpatient, but they're also taking the medicine and just following up very closely. Now, those are all the baseline things. Now, I can tell you that while genotyping can help, there are calculators that help guide you. But what you're looking for are variations that would increase the risk of bleeding predominantly. These are where patients are not basically able to metabolize and we overdose them and they start rapidly having accumulation of the drug in the body. Now, after initiation, that's where it gets a little wonky, right? Because you don't know, every patient is different. Their genetics are different, their diet is different, because their diet is contributing to vitamin K. So the natural antidote to vitamin K antagonist is to ingest vitamin K. So if you ingest too much vitamin K in your diet, which there are variations in foods that have high concentrations of vitamin K, lower concentration, you will cause yourself variability in the INR and therapeutic response of that warfarin, especially if you keep changing your diet. Now, you could be on any diet you want. That's not the problem. The issue is being consistent and being compliant and not changing your medications without telling another provider. So anytime any of those things change in the diet, drugs, compliance, those all influence the INR plus your genetic baseline, which doesn't change obviously, but if you know it, those all impact it. So that influences how frequently you need to bring back a patient to repeat and trend the INR at the beginning to figure out, are they moving fast or are they moving really slow? right? Because remember, it's a vitamin K antagonist. So if my diet was really high in vitamin K, well then I'm going to need more drug to overcome that concentration of vitamin K that I keep ingesting, right? Whereas if I'm on a stable dose of warfarin and then start a new medication that's a 2C9 inhibitor, well, now I need to back off on the warfarin. But early on, typically what we do is we bring people back in a couple days, and we're trying to get to that target INR of 2 to 3. And we're watching how fast they're getting there. If they're rapidly rising, and we know that the half-life of these clotting factors that are floating around the body are going to take about a week to stabilize, and they get to the therapeutic INR by day 2 or 3, well, I already know they're going to go past the goal INR of 2 to 3. Because when they reach steady state and everything balances out and those clotting factors balance out, the patient's going to have a supratherapeutic effect, okay? But our goal is to get them to an interval of usually once per week to every 12 weeks when they're stabilized. This is someone who's consistent, reliable, compliant, predictable, and their INRs are not going all over the place. Now, our goal INR, which you need to memorize and know, is 2 to 3 for most patients. Okay, AFib, DVT, PE. But if you have a mechanical heart valve, it is higher. It's 2.5 to 3.5. Because we don't want that mechanical valve to clot off. That's it for the patient, right? Now, how do we make adjustments? You know, we see the same problem with unfractionated heparin drips. You got to make adjustments based on the PTT. There's no one perfect adjustment for every patient. Doesn't work that way. It's your clinical experience, it's your patient scenario, it's the risk factors, all these things. But people will typically make 5 and 25% dose adjustments up or down, depending on the scenario they're in and what their value, their INR value is, okay? So I know that's frustrating, because it is frustrating. I'm not going to lie to you. That's why there were Coumadin clinics and pharmacists who were very good at manipulating these drugs and understanding them very well in all these complicated scenarios. They were good at manipulating this to create the greatest degree of stability. Okay. Coumadin clinics don't exist much anymore because we have now the DOACs. But the point of the matter is, you're going to make varying differences, and you might suggest one thing and a clinician, another colleague may do something different. They're both potentially right? So you just need to factor it in and do what's right for your patient and communicate that to your patient. What I would say is, if they go in for surgery, start new drugs, change in any clinical status, they need to alert you, right? Because that could cause a dose adjustment. Like I gave you an example of the Bactrim for a UTI can really throw the INR really high, put them at risk for bleeding. Amiodarone, so they have AFib sometimes, right? These patients, I mean, we're using it for AFib to prevent cerebrovascular accidents, right? And so if someone throws them on amiodarone because they went in AFib with RVR and they need something for rate control, well, now I've just interacted with their Coumadin and like put them at high risk for bleed. So what do you do if the INR goes way above 3 for most patients, or 3.5 in the mechanically heart valve patient? Well, you have to put it in the context of what's going on. Is the patient bleeding? You know, not everybody that has an elevated INR is going to bleed. The risk of bleeding goes up, but that doesn't mean you're going to spontaneously bleed. So there are some treatment strategies. Again, not black and white rules. Please don't go there. There is more than one way to do this, and there are variations in policies and procedures that people use. This is just one way of doing it, and a way that I have found in my own clinical practice to work, but also is consistent with other policies and procedures that I have used and trained under. okay? But I recognize there's other ways to do it, and some people might disagree with this. Again, that's okay. But what you're trying to understand here is what is the risk of the patient if you go too low, you reverse them too fast, right? Or you reverse them too much. Remember, this drug is a vitamin K antagonist. So if I'm going to give vitamin K to the patient, if I give them a huge dose, yeah, I might correct it, but I also might move their INR down close to 1. Well, that's not good either. And then I might increase the concentrations in the vitamin K so much in the body that when I start back the warfarin, I now have to give them a bigger dose of warfarin they were on before that was causing the supratherapeutic INR just to override that high dose. So there again is this balance, and it's not clinician specific. It's just influenced by a number of things, and everybody's going to vary. But what you see here is an approach of holding a dose, bring them back, see if it corrects. Holding a dose and giving 1 to 2 or 2 to 3 milligrams of vitamin K and just bring them down a little bit. But typically drastic moves are not necessary until we start getting into therapeutic or INRs that are over 20. That is clearly a problem. Okay, very high risk for bleed, and you really need to give this one consideration where the higher dose of vitamin K is going to be administered. So how do you give it if you're going to use it? Well, there's 3 different ways you can administer vitamin K. You can give it sub-Q, you can give it IV, or you can give it by mouth, okay? Now, most people don't use IV, okay? And we don't want to give it IM because the patient's obviously at increased risk of bleeding, and sticking a needle into the muscle where there's a lot of blood vessels could cause a hematoma, right? And a source of bleeding. We don't need that, right? So don't give it IM. Sub-Q will give a slower onset than IV, but typically we go with the oral route unless there is severe bleeding and they're bleeding in the GI tract, where typically those patients get nauseous and can vomit, and we don't want to interrupt that. An alternative is to use to things like FFP. You can even use what is called PCC, prothrombin complex concentrates, which are basically activated clotting factors, okay? They replace factors 2, 7, 9, and 10 pretty much as you infuse them, you get them, okay? So whether the warfarin is there or not, it doesn't matter. These are the active forms and override any influence of the warfarin at that moment, okay? And so there's different formulations out there that are available. Again, typically they're protocol driven. Pharmacists can be very, very helpful in guiding you into choosing the right drug in the right scenario and how to dose it. Because again, these scenarios can create the other extreme, clotting, right? So it's this constant balance, just like in our body, homeostasis. We don't want to bleed out, but we also don't want to clot. There's this balance in between, right? All right, so now what I'd like to do is kind of wrap things up, okay? First is going back to this table, okay? So what I try to do here, and if you now look at this table, you see these things like the precipitation of an emboli is higher risk with warfarin, very little to none for the other agents. That's one of the biggest disadvantages for this and why warfarin needs bridge therapy. So I hope that tables like this are helpful to you. Feel free again to download it at thisiswhy.health for free. Share it with your friends, colleagues, those kind of things. So warfarin is a vitamin K antagonist, VKA. We commonly use it for AFib and the prevention of cardioembolic strokes, especially when our CHA2DS2-VASc score and our HAS-BLED scores, which we typically use to assess the risk of complications or risk of stroke, but also the risk of bleed, and there's a balance, right? Secondary cardiovascular prevention, especially when no other options are available. And then VTE, treatment and prophylaxis for DVT-PE. Don't forget, mechanical heart valves, antiphospholipid syndrome, Good indication still, okay? Now, this drug works by inhibiting the functional activation, by inhibiting that VKOR, which is an indirect inhibition of the carboxylation of clotting factors that prevent the drugs or those clotting factors from becoming functionally active. But remember, protein CNS have the shortest half-life. They get impacted first, which tips the scale to a pro-coagulant state initially. And that is, again, why you need that bridge therapy. Bleeding is a risk factor, but clotting early on, especially in high doses, patients with hypercoagulable disorders like factor V Leiden, protein CNS deficiency, those patients are at high risk. Dosing, complicated, very patient specific. You're never gonna find written rules for everybody that works for everybody. You're gonna have to be flexible and adjust with their lifestyle, their drugs, their genetics, okay? And it takes about 5-7 days for those therapeutic onset to occur, which is frustrating. If you get yourself in a problem when you're bleeding, vitamin K is the replacement. Just be careful how much you give. And then lastly, it is considered contraindicated in pregnancy. There is some evolving data that some people will use it, but again, historically, and unless you're an expert, I would probably not do that without consulting with somebody first. All right, guys, well, I hope you found this to be helpful. Really appreciate if you'd subscribe to our channel on YouTube. Give us a like. We really appreciate that. It helps us support us in what we're doing for you and for others. I'm Dr. Busti, and so thanks, guys, so much for joining us and sticking with it. I hope you learned a lot and you found it to be useful, even if it's a small pearl here and there. But we look forward to continue to see you in future episodes. So thanks for joining. Take care.